think we have 25 minutes actually for discussion. So I think we can immediately start with the first talk about the bears and about hibernating. Dr. Yazzo. Yeah, I think we don't have enough chairs. I was also thinking about it. But
I would stand.
Okay, then Steven and Luigi maybe. Yeah. I have a question to you. So bears are the only animals who are hibernating. Did you, in that large area of Minnesota, are there any other animals hibernating that would worthwhile looking at to find patterns?
No, there's a lot of animals that are hibernating. Actually, you can get the hibernation induction triggers from woodchucks as well. But there's different types of hibernation. So squirrels hibernate, but they're periodic hibernators. That means they'll hibernate for 2 weeks. Their body temperature goes very low. Then they'll wake up, they'll eat, drink, defecate, urinate, and then go back down. Their body temperature gets very low. So there's different types of hibernation amongst mammals.
Yeah, because this is really amazing so you are saying that, so do we understand anything how, so next to the fatty acids, so do you understand anything how they are not losing any muscle strength, and do we have any, compared also to the other animals?
Yeah, so they're actually turning over muscle. So they're actually turning over proteins, but then they're not urinating. So there's a special bacteria in their gut that turns over the urea. I don't do research on it. We had a group with us that came out and did that. Of course, NASA and other groups are interested for long-term space travel if they could add a bacteria to the gut to recycle the urea and everything. But, you know, there's so many interesting things that they're doing. It's really fascinating.
Pedro?
One of the probably most important points that you might have in your hands to study in the future is the problem of sarcopenia, the loss of muscular mass in adults and old people like me. And you know that this is important because there is a combination of we lose reflex mechanisms, we lose muscle, and then we fall. And when we fall, we can break something, which can be the femur, or we can get, you know, a hemorrhage or anything like this, bleeding in our brain. Now, have you done some research in this area in the sense of to see how they preserve the muscle? Because I love all the part of electrophysiology, of course, but in terms of, you know, of the human being in the future, probably, you know, the dealing with this preservation of muscle is going to be a very important clinical point.
It's a great question. We don't fully understand this still, how they're preserving the muscle. They're turning over the protein. They're actually maintaining their bone as well during hibernation. They're not losing any bone density as well. And it's related to these hibernation induction triggers. It's a cascade of hormones. There's one factor is delta opioid in nature. And you can give delta opioids to non-hibernators, and they will go into this like hibernation-like state. So, I mean, there's receptors for these delta opioids throughout the body. And then, of course, there's ursodeoxycholic acid, which are the bile acids, which has been used in Eastern medicine. And that's used as a medication for liver disease and other things. And whether that could be used for minimizing muscle loss, we don't know yet. But these are important questions we need to consider.
Well, one of the ways to actually minimize muscle loss, not only osteoporosis, is calcium. This is actually vitamin D. Have you looked at the calcium metabolism in these animals?
Yeah, there's a lot of groups that are doing that. University of Michigan, there's a whole group looking at the calcium turnover.
Okay.
There's a lot of great literature out there on it.
Thank you.
What is also fascinating, that pregnancy, no? I mean, it's so did I understand it, why they are hibernating? They are having the pregnancy and then they are feeding their, why hibernating?
Yeah,
so that's completely opposite.
So they mate in May, June, July. And there's the late implantation of the fertilized egg until November. And then the gestation week's only 6 weeks. And then they're born while the mother is hibernating. So the respiratory sinus arrhythmia exists. For the first couple of days, you can see a shift in that. She's a little bit more aroused, but it's not like for, more than a couple hours. And then she's still showing these, super low heart rates, and she just gave birth.
Yes, thank you. I have a question to Stephen. This OpenEP is extremely important. And I mentioned in my talk this Volta device where you use machine learning to advise the cardiologist where to ablate. Can you also store in your system, or have you a systematic way to store the ablation lines and measure the success, and what would be even better, the success rate after 3 months, so that you could set up an open database, because the Volta database is proprietary. No one can use it. And this is the extremely big advantage of your approach.
Yeah, absolutely, Olaf. It's a really important point. And so within the data format, there are defined spaces for recording several pieces of information. So information about the maps. So we have the conventional maps, but we also have a child of that part of the data format where the user can store as many different maps as they would like. Mm-hmm. We do the same for the signal data. So we have some conventional parameters, voltage, unipolar, bipolar, but also it's then extendable. So for example, if there were data like from the Volta type analysis, that would be an ideal place to put that type of data. And then for the therapy, we have the same thing. So we have a standardized way that we have chosen to store the ablation data, and that's all visible within the system as well. What I would say is that the data format is what kind of we have evolved over probably about 10 years now of doing this type of research. But what I'm really keen now, and I guess my pitch to everybody in the room, is that arriving at a universal data standard is not just for one group's prerogative. And it really should involve collaborators from medicine and from engineering, bioengineering, and from industry, hopefully, to bring together everybody to maybe have like OpenEP V2, which is everybody's design meeting all of the needs, rather than it just being what we have put forward as the appropriate approach.
Yes, thank you.
Dr. Zhao is online or not? I'm not sure.
No, he mentioned that he had to leave for the airport. Yeah.
Well, then we can continue indeed with Steven. So I am a big fan, as you know, of OpenEP, and so it's this big data possibility is amazing. Now, I am not sure regarding the Volta, because we know that AF termination is not predictive of success first. Secondly, even if you terminate AF, you look at those sites, the question is, in the meantime, continue burning. There is a time lag between termination because of the waves needing to collide with each other. So that's also, there are a lot of problems with that, I find. And also the fact that we are burning all over the place to correlate. But I am a very big fan. And tell me about a little bit that, when we have these electroanatomical maps, we need to edit them to make any sense of it. That's the first place. That big data gives you the option to that error. So the errors that we are having on these unedited maps, that you have, so having a lots of data is probably decreasing this kind of error, or we are making the same error in every map. I'm not sure about that. But what do you think about this? That these are unedited electroanatomical maps. They are not corrected, and we know that there are, serious mistakes in this map.
Yeah, absolutely. And that I alluded to some of the initial studies that we have planned with the system. And actually, we were very fortunate to get funding from the MRC for a clinical fellow who is going to have the maybe the envious or unenviable task of reannotating all of the first about 2,500 maps that come through the system. So we will have that initial piece of labeling or reannotation done correctly. So, deleting the electrograms, putting the activation times, etc., in the correct places. That data will be available to everybody, and so I hope that some of the real leaders in the machine learning, for example, may be able to then take that data and develop better algorithms that can then propagate through the future of the study, because it's not maybe possible for all of those maps to be reannotated with such a labor-intensive process in the future. But I think your question also speaks to perhaps a bigger question about how we collect the data within electrophysiology. That I'm aware of, we don't even at the moment have knowledge on comparative studies. If you were to map the same patient with the Carta system or with the EnSight system or whichever system you choose, would we come up with the same information? I mean, I suspect in terms of an activation map, we might do, but in terms of a substrate map, a voltage map, I think the jury is out there. So again, one of the powers of the big data is we can start to look for systematic biases within the data. So maybe we're not going to have, paired data sets within one patient, but if every EnSight case across thousands of patients is slightly lower voltage than a Carta case, that will start to give us some information about the importance of perhaps thinking about ways to standardize between systems.
Yeah, because do you have the information which catheters are used during the procedure?
Yeah, so I didn't show too much about it, but we'll have the proposal. The other thing I should say is that we're at the setup stage at the moment. So we've had ethics, we've got confidentiality group next week. We're working very hard with contracts, and we hope to be live from January. So some of this might change. But the data set will consist of a case record form, so the important clinical characteristics, the text-based procedural reports, the imaging data that has gone along pre-procedure, the ECG data, and the electrophysiological data. And then on the other side of the puzzle is the linkage to the clinical outcomes. So it will be quite an inclusive data set, which hopefully can be used for many of the types of questions that you know.
Yeah, so you will have the follow-up.
Yeah.
And this is only UK data, so the 2,500.
Well, at the moment, but one of the big pieces in the final work package of the study is about internationalization. And so I'm really keen that we can certainly look to move to collaborations with the EU and then ultimately, hopefully, with the US as well. I think that there's going to be big questions around data transfer, but I hope that maybe the easier piece to solve is perhaps researchers in those areas accessing the data that we have as a first step for collaboration. And then maybe we can start to think about ways that we can bring together data. Federated learning is one way of doing that in the future.
Yes, I have a question to Luigi. Thank you for your great talk. And I've heard, and at least we also had one simulation where we observed fluctuations in the pathway. The sinus node has an opening and very tiny changes in the way the wave goes out of this into the terminal crest. It makes changes. I also came across a publication of I think it was the group in Nijmegen, who observed tiny differences in the P wave from beat to beat. Normally you average because the P wave is so small, but they were able to measure in single P wave from single beats, and they were all slightly different. Did you also observe something like that?
Yes, absolutely. Thank you for your question. So actually, of course, there is a variability in beat to beat, both in sinus node exit and in conduction pathway. Actually, the conduction pathways are more stable over time, but it's more the endocardial sinus node exit site that changed more. So what we did in this study, we analyzed 2 consecutive beats and from also 2 independent operators, so to ensure consistency. So these data are a mean of 2 consecutive beats and 2 different operators, but the answer is yes. Of course, it depends also on the heart rate, because a slightly change of the heart rate will also change the sinus node exit side, a bit lower, a bit higher. But no, the conduction pathways actually are slightly more stable because it's these are both anatomical and functional pathways, and it depends also on sourcing mismatch. So basically, they need to be there because of the electrophysiological properties.
Do these fluctuations might have any diagnostic value, or is it just interesting and nothing else?
Yeah, that's a good question. Actually, for us, it's important when we map the sinus node to map the higher portion, because of course that's the portion that we want to spare when we ablate, or when we want to ablate the SNT that we want to cut above that. So it depends. From a clinical standpoint, it's important, of course, but it depends also on the indication of the procedure you are performing.
Luigi, I really love those maps and look forward to hopefully collaborating on it. But my question was, have you had any cases of synatrial exit block? And do you see where the block occurs?
Thank you for your question. No, so actually in sick sinus syndrome, we have so patient in which the sinus node is diseased, but still we are mapping the P wave. So actually, I'm not aware of any patient with the synodral exit block, but of course we look forward also if you in your library find some cases, maybe from other center, we can collaborate on that because that would be interesting. Yeah, absolutely.
Luigi, I didn't catch that this the peak frequency maps were endocardial, right?
Yes.
Only
Only
endocardial.
endocardial, yes.
Yeah, because I'm wondering that the Bachmann is normal epicardial structure, so you would expect. Did you see any difference in the Bachmann peak frequency component as opposed to the other ones? And I'm also interested when you remap after your procedure, after the hybrid procedure, you remap the patients. What do you see then? Because the sites where you are, yeah.
Thank you. So actually, the biggest limitation of the study is indeed that we don't have in all patient epicardial map, and we have a small group that we perform indeed the epicardial map, so we can look into that. The point is that after ablation, of course, we have that the superior pathway usually it's like cut, so that of course there is a disconnection between SVC and the sinus node, so the superior pathway is cut and all the rest stays the same. That's the point of the ablation, so that is sinus node sparing, so normally we don't want to cut the sinus node. But yes, and also in sick sinus syndrome we see that usually the superior pathway is less prominent, so they have less frequently the superior pathway that goes up. For the Bachmann bundle, actually that's very interesting because we were discussing yesterday with Neil, so he was showing us the picture, so the histological section, and he was showing us actually how the anatomy of the Bachmann bundle is important for us because there is a fibrous tissue that is on the right atrial side. So when we put the screw in, so the lead in, we have to be careful about this fibrous triangle. And we were talking about this, and we were also supposing that maybe what we see when we map this part of the septum, this high frequency part of the septum, is maybe this fibrous triangle. So maybe, as you said, there is something different in mapping the Bachmann bundle from the endocardial side, because maybe this fibrous tissue gives a different electrical property. So, but this is really new, so I really want to explore this together with Neil to perform some map and some histological session to understand this, and this is especially important for the Bachmann bundle pacing.
We would have time for questions from the audience. You are really invited. I mean, time is precisely over, but I think the organizers would allow us for another. Yes.
Yes, for the first speaker, do bears do rhythm disturbances? Have you documented that?
Yeah.
Atrial fibrillation, extrasystoles?
No, which was shocking. We really never saw anything other than these dramatic respiratory sinus arrhythmias.
Yeah.
No, I mean, once they go at these low heart rates, it's a consistent heart rate of, for that bear of 5 beats per minute consistently till they inhale again. So, we looked hard for it and saw nothing. I think one bear had a bigeminy. That was it. But that was rare. We did see one bear have an arrhythmia, but it was hit by a car. And that's when it had its arrhythmia, went into VTAC, VFib, and died. That's it.
From stress.
Thank you.
From the stress?
No, I think it was the impact from the car.
Oh, the contusion. But Stefan, why were you? I mean, Stefan is an outstanding anesthesiologist. Why were you asking that? What would you have expected? You thought that because of the.
I think it would be interesting.
Yeah.
Because we learn maybe from animals and to transpose to. I don't.
And do you think hibernating the brain's process has something to do with anesthesia or not?
I think so. So I would expect that bears would do extrasystoles in daily life.
Yeah.
So in summer or in spring.
We've seen that their heart rates can go from pretty much at rest in the summer, about 90 to 100, up to 250 beats per minute. And typically, you know, we're trying to track those events. Often it's you know, other bears. So you're looking at that. We actually had some bears with a mounted camera on the front of their collar, so we could see what they were doing throughout the year. And you know, they're interacting with other bears. Then there's a hunting season. They'll actually go to baits. And they'll have a higher heart rate with going to a bait, as if they know that they might be shot. It's really fascinating.
And what's the median age of?
So that's a great question. The oldest documented bear in the world was in Minnesota, was 39 and a half years old. The average bear in our study, some of them are in their 15s and 20s. The average age of a bear in Minnesota is 5 or 6 years old, because we have an active hunting season.
Oh.
So it's an advantage to be in our studies. You'll live longer, because the hunters are asked not to shoot the collared bears with ear tags.
Thank you.
And Jean-Baptiste, you had a question. Professor Kierkegaard is the...
Just a comment I wanted to ask.
Go ahead
It's a small joke I was asking.
to close the session.
Yes, the driver also had arrhythmia when he hit the bed. It's fascinating what you do. Would it be possible to come with you, or you need to be really trained to do all these? Because you walk for miles in the.
You know, we do bring people out with us, and you know, Carlo wants to come again. I said, you better get in shape. And yeah, well, with Dr. Lasky, one of the first times we went was Colorado and Wyoming, and we were at like 10,000 feet. And he had to go back carrying extra weight, and he nearly passed out. So it is stressful. I mean, you know, I actually work out and train to do all this. But it's super fun.
That's why you're also working out, preparing for this trip, no?
You close this session, or?
Are you? What?
Yeah, so with this, we've closed the session. I say thank you to all the interesting lectures, to all those who contributed to the discussion, and I wish you a good lunch. And we meet here in precisely 1 hour, right?